Good afternoon, everyone, and thank you for joining the Justice Center for today's webinar entitled Innovative Law Enforcement Strategies for Interacting with People with Mental Illnesses Frequently Require Emergency and Crisis Services. For those who are unfamiliar with the Justice Center, I'd like to provide you with a very brief overview. The Council of State Governments Justice Center is a national nonprofit organization that serves policymakers at the local, state, and federal levels from all branches of government. Staff provide practical, nonpartisan advice and consensus-driven strategies informed by available evidence to increase public safety and strengthen communities. I'd like to introduce you to our moderator and speakers. We have Dr. Fred Osher. Dr. Osher is the Director of Health Systems and Services Policy at the Council of State Governments Justice Center. Dr. Osher provides technical assistance to state and local governments across the country seeking to improve their responses to people who have mental health and or substance use disorders and are involved in the criminal justice system. Before joining the Justice Center, Dr. Osher served as the Director of the Center for Behavioral Health, Justice, and Public Policy and as an Associate Professor of Psychiatry at the University of Maryland School of Medicine. He has published extensively in the areas of homelessness, community psychiatry, co-occurring mental health, and addictive disorders, and effective approaches to persons with behavioral disorders within criminal justice settings. He received his BA from Harvard University and MD from Wayne State University. Welcome to Dr. Osher. Our speakers today, we have Ms. Ann McLeod, and Ms. Ann McLeod is the Program Director of the Crisis Intervention Response Team, CIRT for short, and Chronic Consumer Stabilization Initiative at the Mental Health and Mental Retardation Authority of Harris County, Texas. CIRT and CCSA are collaborations between the Houston Police Department and HMRA. Through extensive background in inpatient psychiatric hospitals, Ms. McLeod acquired experience with inpatient, outpatient clients, diagnostics, and facilitated individual group therapy. Ms. McLeod has presented at international, national, and regional conferences. Her volunteer experience includes the Community Emergency Response Team, the President's Citizens Corps, and the Crisis Hotline in Houston. Ms. McLeod holds a degree in clinical psychology. She is a licensed professional counselor supervisor in the state of Texas and is certified by the National Board for Certified Counselors. Welcome to Ms. McLeod. We also have Officer Lawrence Pate, and Officer Pate is an investigator in the Mental Health Unit at the Houston Police Department, where he serves as a liaison to the CCSI program. Pate also investigates firearms cases involving people with mental illnesses. He has earned his Crisis Intervention Team certification in 2008 and was one of the original members of the Houston Crisis Intervention Response Team. During his career, he has received several commendations, including a Chief of Police citation. Officer Pate received his BS in Computer Engineering Technology from Prairie View A&M University and his MS in Strategic Leadership from Mountain State University. Welcome to Officer Pate. And last but not least, we have Detective 3 Charles Dempsey. Detective Dempsey is the officer in charge of the Case Assessment Management Program, CAMP for short, Mental Evaluation Unit, and Crisis Support Section at the Los Angeles Police Department. Detective Dempsey has over 25 years of law enforcement experience in varied assignments with both the Los Angeles Police Department and the Department of Defense. Detective Dempsey is also a member of the Mental Health Service Act, MHSA, Innovations Committee, and the Los Angeles County System Lead-Up Team, which are charged with looking at innovative solutions and assisting those suffering from a mental illness. Detective Dempsey has a diverse educational background, which includes an AS in nursing, a certification from the Defense Language Institute Foreign Language Center in German, studied in urban geography and foreign languages, Spanish, and most recently the completion of a clinical training program at the National Center for Post-Traumatic Stress Disorder in Menlo Park, California. Welcome to Detective Dempsey. Our webinar today will consist of opening remarks from Dr. Fred Osher and presentations from each of our panelists. At the end, you'll be able to ask questions and get answers from our experts. And we also provide links at the end where you can find the information given in this presentation, as well as links to live webinars and other information on the Justice Center's website. And with that, I would like to start with Dr. Fred Osher for some opening remarks.
Thank you, Whitney, and thanks to everyone for taking time out of their busy days to join us on a topic that I think has a lot of common interest around the country and addresses one of the central issues of our time, the overrepresentation of people with mental illness and behavioral disorders in our correctional settings. And certainly the advantage of thinking about the front-end responses, and today our focus will be on law enforcement, is to think about the multiplier effect that has if you can provide alternatives to custody and interact with individuals in ways that prevent their penetration into the criminal justice settings. It is the case that most communities throughout the country, we are going to focus on that small group of individuals that draw on a disproportionate amount of services in the community. High utilizers is one of the names that are given to these groups, but we all know folks within our own settings that are frequent callers into dispatch and require regular and oftentimes crisis intervention services. Sometimes their access to health care, affordable housing, employment, and other social services is limited, and particularly in the times that we're in with the budgetary pressures, we experience that's even more so. A subset of this group has serious mental illnesses, behavioral disorders, and frequent encounters with law enforcement and emergency room personnel. And as a result, first responders, including law enforcement officers and emergency medical technicians, ER personnel, and a variety of staff are overburdened. It was brought to national attention and prominence in an article that was published in the New Yorker, written by Malcolm Gladwell, entitled $1 Million Murray. And I just want to read an excerpt from this. If you haven't read it before, I think many people recognize the challenges that Reno, Nevada faced. From the article, Murray was a bear of a man, an ex-Marine, 6 feet tall and heavy-set, and when he fell down, which he did nearly every day, it could take 2 or 3 men to pick him up. He had black hair and olive skin. On the street, they called him Smokey. He was missing most of his teeth. He had a wonderful smile. People loved Murray. His chosen drink was vodka. A runner, we could pick him up several times a day. Patrick O'Brien, who's a bicycle cop in downtown Reno, said, he's gone on some amazing runners. He would get picked up, get detoxed, and then back out in a couple hours later and start up again. I've been a police officer for 15 years, O'Brien's partner, Steve John, said. I picked up Murray my whole career, literally. Officer O'Brien and John spent at least half of their time dealing with people like Murray. They were as much caseworkers as police officers, and they knew they weren't the only ones involved. When someone passed out on the street and there was a one-down call to the paramedics, there were 4 people in the ambulance. The patients sometimes stayed at the hospital for days because living on the streets in a state of almost constant intoxication was a reliable way of getting sick. None of that, surely, could be cheap. Johns and O'Brien realized that if you totaled up all of Murray's hospital bills for the 10 years he'd been on the streets, as well as substance abuse treatment costs, doctor's fees, and other expenses, Murray probably ran up a medical bill as large as anyone in the state of Nevada. It cost $1 million not to do something about Murray, Officer O'Brien said. And the Murray bar died on the streets of Reno. And every community has their $1 million Murrays. While care and an enormous amount of resources are used in addressing the needs of these individuals, oftentimes ineffectively. And it takes to respond to individuals can have a negative impact on public safety, demoralization or frustration on the part of police officers. Individuals are frequently involved in criminal activities, either as perpetrators or victims. The court processes are clogged up by their presence. Resources are diverted from true emergencies. Administrators and line staff question whether earlier intervention or alternative responses could produce better results. And that's why we're here today. We have on the phone groups that will talk to us about their approaches to the high utilizers in their community. As speak, and as you consider your own I'd like you to consider these key programmatic issues. How do you define the cohort of folks that have met criteria for high utilizer, and then how do you identify them? When identified, how do you share information between systems that are collaborating to improve responses? With community, what are alternative dispositions to jail and ER that may be available? And then how do you pay for any of this? What are the financing mechanisms that are available for the strategies and services that you may be considering? And lastly, how do we know if what you've done works? I think you'll find in our two presentations today answers to several of these questions, and we invite all of you to put questions for our question and answer series at the end of their presentations. At this point, I wish to turn it over to a patient on our chronic consumer stabilization initiative.
Thank you, Josh. The Chronic Consumer Stabilization Initiative is the agency collaboration between the Houston Police Department and M.H. Murray of Harris County. As Dr. Usher was stating before, policing and dealing with these individuals with mental health issues typically is a reactive method. Officers experience frequent encounters with persons with chronic mental illness, and often there's no other solution other than arresting some of these individuals or taking them in for emergency detention orders. Officers tend to be frustrated, and they continuously come in contact with these individuals, and the police department decided that we needed to look at these people in a different light through our statistical database. It's estimated that 10% of all police calls involve a person in a mental health crisis. That's very significant in seeing that the Houston Police Department responded to approximately 25,000 CIE-related calls within 2011. The whole program of CCSI and CERT was born out of two unfortunate incidents that occurred in 2007 within a short period of time. In the first incident in May, this young lady, 42-year-old female with a history of schizophrenia, continuously came to police headquarters making claims of laser beams being shot through her head, food being poisoned, people stealing her identity, all sorts of outlandish claims that can never be proven. The young lady had a serious history of psychiatric evaluations and being taken to the hospital. She had several 911 emergency calls. She also had several times that she came to the police department or actually came to police headquarters. On this fateful day, she entered the police lobby wearing several layers of clothes, and she had a knife on her person. She brandished this knife toward the officers that were working the front desk. They immediately drew their weapons, gave her verbal commands to drop her knife. She continued to come towards them, actually stabbing herself in the head with this knife. And she continued to come towards the officers. They continued to retreat, and unfortunately got close enough where they felt that their life was in danger, and they shot and killed this young lady inside police headquarters where she was coming for help. The next occurred just a few months later in July. This young man had a lengthy history of schizophrenia. He had been detained by HPD 3 times within the prior year and recently released from the Harris County Psychiatric Center 1 week prior to his final encounter with the police. During the time period, he had stopped taking his medication. He began to deteriorate. His mother took him to the Harris County Psychiatric Center but was turned away because they stated that it was the weekend and they could not admit him during weekend hours. Excuse me. Harris County Psychiatric Center to his mother to take him back home and call 911 to have the police come out and take him to the psychiatric emergency room so that he could receive help. Once he arrived on the scene, they came outside with a pipe that had concrete still at the bottom of it, and swinging this pipe at the officers. The officer retreated. He chased them around their patrol car, bashing their patrol car, essentially pulverizing it, where it didn't even look like a car by the time he got done with it. And he continued to come towards the officers and they drew their weapons. One officer could no longer reach fell and shot and fired his weapon, unfortunately killing this gentleman. Looking at all these issues, we have to look at what CCSI actually is. And as I stated before, it's a collaboration between the Houston Police Department and MHMRA of Harris County. And it was designed to identify and engage and provide services to individuals who are diagnosed with serious and persistent mental illness and who continuously come into contact with the Houston Police Department. Now, yourself, why CCSI is needed? Well, if you look at these incidents, these encounters between police and these people with serious mental illness continue to increase at an alarming rate, not only in Houston but also across the United States. CIT or mental health calls can be some of the potentially most dangerous calls, not only for the officer but also for the consumer, and it'd be very time-consuming and very litigious to law enforcement throughout the community. And I can turn this over to Ms. Ann McLeod.
Okay. So what were our goals when we started this program? One of the main goals was just to reduce the number of interactions with Houston Police Department with these clients and these the officers, because from a very young age, these clients are taught to call 911 if there's an emergency. If I'm not getting something that I need to call 911. They would just pick up the phone, call the police when they weren't getting any of their needs met. So our primary objective was to just reduce the number of interactions between these clients and the police department. Another goal was to identify the unmet needs and barriers in the community. Another goal was to link and coordinate clients with needed mental health treatment and psychosocial services. We wanted to also provide support and education to the individual and to their family members. These were our goals. The eligibility criteria was that they had to have 3 or more admissions to the Neuropsychiatric Center, which is the NPC, by the police department, and they had to have excessive phone calls made to police by either themselves or others, families or collaterals on their behalf. They had to have a high frequency of contact with patrol officers in general, or especially the crisis intervention response team. Not only were they people who came into interaction frequently with the police department or with the emergency services, but they also had to come in contact with the fire department, ambulance, hospital, ER, etc. We shared data to give us background on how we could identify these people, and then we collected data. Data was entered into one of 2 systems, either the HD database, and then our agency also has a services database. The concerns were identified. The case managers started working to diligently engage these consumers and these individuals into services. We have a biweekly meeting with the police department and our agency to discuss the progress. And of course, Officer Pate and I are available each day to provide services to either the officers that are on the streets or either the case managers that are working with these individuals. We have currently 2 full-time case managers. They each have 20 clients. We have a part-time psych tech who was funded to us by the Simmons Foundation. This psych tech assists the case managers in getting these clients back and forth to interviews, getting back and forth to other necessary appointments that they may have throughout the day, to allow the case managers to provide more intensive case management with getting their needs met. We have an HPD officer who is assigned full-time as a program liaison. Supervision is provided by myself from the Mental Health Authority of Harris County, and we also have a sergeant. And then we have administrative oversight provided by an assistant deputy for crisis services and a lieutenant with the mental health unit. So what worked? Overall, we decreased the number of daily encounters with the mentally ill and HPD. The program started in 2009. Since then, we have not had any deadly encounters. And I feel very honored to be a part of a community that was proactive to those two incidents that Officer Pate was mentioning earlier. The program has decreased the number of interactions between these identified clients and the police department by approximately 47%. Our admissions to the Neuropsychiatric Center, which is our emergency center, decreased by 21%. Our admissions to the Harris County Psychiatric Center, which is our local psychiatric hospital, decreased by 51%. So what worked? Calls were diverted from 911 by providing case manager number to these clients. I think that is the primary objective that worked, because when the clients were having an emergency or having a crisis, they knew that they could just pick up the phone and call their case manager, and their case manager would be there. The people that we hired understood that when they came on board with this program, yes, their office hours or actual hours were probably 8 to 5. They would always be on call 24/7. And that has helped, because it has helped these clients to understand that somebody is going to be there. They can call somebody else besides 911. The case managers are also very strong advocates for these clients. If they're in a personal care home and the personal care home is not helping them provide medication, they can get the case managers who will go in there and do some education. All these clients were being exploited by their families. The families were the payees to their benefits, and then by the 5th of the month, they had kicked the client out and they were on their own on the streets. Well, the case managers have actually made some reports to Social Security, and that has stopped. The thing that has saved us with this program in Texas is that we don't have the funding restrictions and the state mandates that other programs within our agency have. So there's not a certain number of times that they can see the client, and then they won't be reimbursed for that. We don't offer services based on times per service. We based on service. So if the case manager needs to meet with someone 10 times a week, they go ahead and do that. There's not, if you meet with this person every time, you won't get your money. We just provide the services. So for those who are dealing with funding, that's a big freedom there. We couldn't do this program in our agency without the support and involvement of the Houston Police Department. The police department had access to these people showing up all over the city. Within our agency, we just have one place. We just have our emergency room. With the police department, if they showed up on the north side of town or the south side of town, they were able to know when they came in contact with their agency. We also have support from the district attorney's office. These people come in contact with the police department does not necessarily mean that each contact was a criminal contact. The police department would maybe pick this person up and they were psychotic. But if there was an event where charges needed to be pressed for some incident, we have a contact within the district attorney's office, and this person has attended our staffing and has able to go back to the judge and offer an alternative to a treatment plan versus just being in jail. Dependability of the case managers. The case managers, they give their word that they're going to be there. They're there. They attend the doctor's appointments with these clients. So the doctors have also said they've enjoyed having the case managers on board, because if the client doesn't understand everything that's being said within a 15 or 20-minute doctor's visit, then the case manager can reiterate to the client later on what was said by the doctor. And then the networking. We establish ourselves here in the city of Houston, not only among our agency and the police department, but psychiatrists, day programs, hospital rooms, other emergency centers. So if one of our clients does happen to show up at an emergency room, we get a call.
Let's quickly take a look at a profile of a current CCSI client. Individual actually is one of my favorite individuals to work with. His history is schizophrenia, numerous hospitalizations for mental illness throughout his history. He's trespassed at police headquarters, and he also frequents the downtown district, close to several federal buildings. He's known for waving knives and screaming that he's doing God's work, so he can be potentially dangerous. This individual actually shot a citizen and was subsequently shot by police. He did not die. He was charged with attempted murder but found not guilty by reason of insanity. And he also has been charged with robbery, sentenced to robbery of a bank, in fact, and sentenced to 37 months in federal prison. He had 23 police contacts and 5 arrests prior to coming into contact with or coming into the program of CCSI. He was added to the program in January of 2011, and sitting on the program, he's made a complete turnaround. He's only had 1 contact with the police and no arrests since being on the program. He's currently living in a personal care home, and he is taking his medications regularly through a shot. His case manager is very, very active in his everyday life, making sure that he's staying on track, and he has not had any issues, which is a blessing considering this gentleman's history. Looking at the side of everything, you have to consider the numbers of what this gentleman has cost to the community and what the potential cost avoidance is. Looking at his psychiatric hospitalizations that we have on record just here in the Houston and surrounding areas, that's not including nationwide anywhere else he's been, $31,000 for going to psychiatric hospitalizations. And instead of going through the numbers, I prefer that the attendees would take a look at the numbers as opposed to us talking about them, because that's not really the important part. The important part is that we're doing a great job with making sure that this individual is staying out of trouble and staying out of the psychiatric hospital and living a full and productive life. Another example of a client on the program is here who suffers from major depressive disorder and has had several suicide attempts. One of his worst suicide attempts was when he attempted to shoot himself in the face, and he survived that after he shot himself with a shotgun. And he's known to be a recluse in his apartment. He does abuse drugs and alcohol. He does have a diagnosis along with his dependents. And he had 3 attempts to disarm police officers, several police contacts, and he's also requested officers to shoot him or to kill him, asking for suicide by cop. So as you can tell, most police interactions with him can be potentially dangerous. Looking at his history, he had 16 police contacts and 2 arrests prior to being on the program. After being added on the program, he's had 3 contacts with the police, and he is attending his doctor's visits regularly. He is taking his medication regularly, and he is still living himself, but he does not call the police as often. He does call his case manager, and she is able to deal with some of the issues that he has that he would normally call police for. So it's not coming into contact with him as much, which is a blessing. The next slide is also looking at his before and after, or his cost avoidance. And as said before, we prefer not to get to the numbers of everything. If any of the attendees had any questions in regards to how we came up with these numbers, you can feel free to email me or call. I'll get back to you as soon as possible to give you a breakdown of the numbers that we have.
So our program goals are to expand our program capacity. We were actually able to go before City Council a week or 2 ago, and yesterday they actually approved for us to expand by 100%. So we're going to get 2 more case managers, which will increase our capacity to 60. We also are about to look into renewing our Simmons grant so we can keep our psych tech-ons who can assist with the case managers. We're also implementing a Medical Alert bracelet program. I'm sure most of you are familiar with the Medical Alert program, where you wear a little bracelet or a medallion around your neck where the EMS or emergency providers can identify what's exactly going on with you. Well, mental health, mental illness is part of DC9 code. It is a medical diagnosis, so we are allowing the consumers who are willing to participate in this program to participate in the program. So if they are psychotic and somebody does find them wandering in the park, they will be able to know who their case manager is and where they're currently receiving services and what their diagnosis is and what's wrong with them. So this is a slide with awards and recognitions. We were a recipient of the 2010 International Chief Police Community Policing Award. We participated in the problem-oriented policy. We were a finalist in 2010 for the Herman Goldstein Award. And then, as I said earlier, we were a recipient of the 2011 Simmons Foundation grant.
Well, thank you very much for that, and we will hold question and answers for the entire presentation until both groups have presented. And now we'll move on to discussion and description of the case assessment management program out of the LAPD. Detective Dempsey.
Thank you. First of all, I'd just like to, hats off to Houston and Harris County for the work that they're doing. This type of work is innovative, it's problem solving, and the more collaborative efforts that in communities and regions across the country, the more effectively we're going to be able to manage these emerging issues. Just a little bit of a history before I get into some of the details of the slides. The Los Angeles County Department of Mental Health and LAPD have had a long-established relationship going back to 1993 when the SMART model was introduced, which is a CoResponder model. And from 1993 forward until the establishment of the camp, the relationship between the two agencies has been full and strong, which includes not only the SMART model, but a CIT model for first responders and patrol officers. As we realized was, while CIT is an excellent first responder model for the patrol officers in the field, providing them the opportunity to recognize, assess, and intervene dealing with persons who are suffering from a illness or a mental health crisis, and providing them with the secondary co-responder model, the SMART teams, to manage the crisis in the field more effectively. We realized that we were having a high recidivism rate among the subjects and clients that we were dealing with, both on the Department of Mental Health side and the PD side. So in 2004, we did a study looking at both of our systems of response and care, and came up and identified 67 subjects who had 12 or more contacts with either the police department or Department of Mental Health, and these are emergency type contacts. And the thought was put forward that we had some sort of intensive case management to work with and manage these individuals and their systems of care to prevent them from becoming the result of an emergency for service. In 2007, we looked back after the establishment of the program, and we did a statistical sampling of the high utilizers that had been identified in the initial study. And at the end of it, we looked and received a very satisfying number. We assessed and got about $1.2 million in savings from the prevention strategies that would have been put in place in managing and dealing with these individuals and preventing them from utilizing the emergency county services. And that didn't take into account the cost of the services from the side and the fire department response, to the nuts and bolts of how our program is put together. The program has one LAPD detective supervisor, which is myself, and there is a clinical supervisor. We act as gatekeepers to the program, So when the referrals or the referrals for services come to us on these individuals who have been identified, we act as case managers and navigators. The case is assigned to one of the 6 teams, which consists of a law enforcement officer or detective and a mental health worker from the County of Los Angeles. The unique part is that we are not only co-deployed, we are also co-housed. So we're actually housed in one office building, so all of the records on the side and the mental health side are accessible to both agencies and to both members of the team. The team is deployed 5 days a week, and it's considered the follow-up component of the CoResponder model, which is deployed 7 days a week. Basically, the partnership is a proactive end model. We want to get out there and get in front of these calls once we've identified these individuals and the type of barriers or problems that are causing them to seek emergency services, as opposed to them being or accessing mental health services outside of the emergency service system. The criteria. Now, the criteria is pretty flexible, but we looked at what was the biggest drain on mental health services and law enforcement services in the city and the county, and we came up with this criterion just as a baseline for us to assess as to whether or not these individuals needed to be assigned to the investigative or the follow-up team. The subject was the focus of a barricade scenario or critical incident, and there has to be a mental health component involved with that. It has been placed on a minimum of 6 mental health holds within 1 year, and the initial one was 12, but then we realized that we were missing some because when interventions occurred, we were able to successfully engage these individuals and link them to services. We would have gaps of 1 month or up to 18 months, and if we put the threshold at 12, sometimes we kind of missed the pattern, so we lowered it down to 6. Contacts with emergency services and members of the community where these subjects' activities are increasingly violent due to their mental illness. The subject has attempted suicide by cop at the hands of enforcement, and has been involved in a use of force with officers, and all of these are a catalyst of them suffering from a mental illness. The other thing that we very much are very proactive in is the mental health holds or the interventions where there is a weapon involved. California has some very unique laws that allow us to go out, seize the firearms, keep them safe from the individual. If the individual's crisis has passed, they have relief through the court system to have their Second Amendment right returned to them. But our motto or our thought process is remove the instrument, decrease the potential for lethality, and then allow the court to progress that and decide whether or not that individual has the right to bear back. The most important thing, and kind of like what they do over in Houston and Harris County, is the CAMP philosophy is one where the mental health professional is the lead. The CT model, the SMART model, which is the CoResponder model, those are more law enforcement-led models where there's a crisis in the street, uniformed officers are responding, and the lead in those contacts are generally the law enforcement officer who is on scene. The CAMP model, it's a more case management type model, and the focus of the follow-up and intervention is guided by the mental health clinician. And it's really important that when you establish these type of programs and you're looking at generating some sort of a model, that you establish a memorandum of understanding between the two agencies. What this does is really establishes the parameters of the relationship and allows for information sharing. With information, we're pretty much doomed to repeat incidents where the intervention strategies have not been effective. So having all the information on the table and understanding who and what we're dealing with, we can be more effective in how we go about providing an effective intervention strategy. And I get this from my team members all the time, talking about the name of the unit being CAMP, being a Case Assessment Management Program, but really what they remind me every single day is that it's about risk assessment and management, because that's what we're trying to do. We're trying to mitigate the risk and decrease the potential for adverse outcomes. The cases are referred to the teams based on the level and immediacy of the risk. So numerous contacts could be a criterion, a violent encounter with officers or a community member, something that would cause us to believe that the individual and or the community were at higher risk based on this individual's actions when they were decompensating either in the community or in the home. Referral sources are varied. We get them from law enforcement within the city, because LAPD is not the only law enforcement agency here. We have very tight relationships with the university police, the private security companies, parole, probation, the courts. Sometimes we'll have an individual who's before a judge, and our relationships with the city attorney and district attorney will have them generate a call to us where they believe that the individual will be best served by diversion, but they don't want to just divert them and or put the case over without some sort of follow-up component. The mental health community through the county has a door to us also. The hospitals, the mental health providers, the community groups, the individuals out there who are having the day-to-day hands-on contact with these individuals besides the emergency services can certainly give us a call and refer cases to us. So we're very open. And citizens and community groups, we go out to community meetings, service area meetings, where they identify particular individuals who perhaps the citizens haven't known with them so long that they say, well, I'm not going to call John. He'll just stop what he's doing, and then the progression continues. So when we go to these meetings, we'll sit and we'll talk with the community members or the providers, and they'll provide us these individuals' information, and then we'll conduct follow-ups. Back to the MOA, talking about information sharing and how it's extremely important that we understand the guides of HIPAA and CORI. Of course, HIPAA being the healthcare privacy law, and CORI being criminal offender record, which basically is law enforcement only information. Having the total picture of the individual that you're dealing with allows you to develop an intervention strategy that's going to be complete. We only address it on the law enforcement side and don't look at the mental health side or the health services side. We're missing a big part of the picture. And on the other side, if we're looking at the individual solely from the mental health and health services side, and there's a criminal history or criminal or law enforcement contact history, and have that information, then we're not dealing with this individual on a complete picture. So being co-housed, being where the information is available to both investigators in a timely, real-time manner, and allowing them to take those cases, develop them, and then develop intervention strategies is extremely important for proper case management and good outcomes. The teams, every single day when they get cases, they look at them, they work them up, and then they sit down, and before they make any type of a contact with either the individual, the caregiver, the family member, or going to court, they develop a strategy, a like strategy. So when they go into these situations, there's an understanding of what the expectations are from the contact, both sides of the aisle. I always like to call it dual tracking, where we have two very different disciplines traveling down the same road, the same goal, but on traveling in different lanes. So the goal is to ensure that we both know what we're doing on this trip down to that common goal of a good intervention and a good outcome. Kitchen services, intervention strategies. Yeah, we have outcome measures, and believe me, they're like moving targets. We continually look at things. Is this something that we want to capture? Is this something that we want to decide as a measurement? But basically, these are the basic ones that we look at as far as, I'm sorry, I'm one step ahead, but look at the outcomes and outcomes measures. Importance for us is linkage to mental health services. We want to ensure that the individual, if they're either through outpatient or involuntary inpatient services, that the individual is linked in a solid manner. Just simply referring an individual to a care provider or to a service is insufficient. We want to look at when an individual does go before a magistrate or judge or commissioner, where they're in court, and while we advocate for diversion, because that's within the court purview, we offer the court alternatives. We'll say, well, if this individual is a condition of the probation is a mandated mental health service, Your Honor, we will ensure that we set up that linkage and make sure that that individual is complying with those mandates from the court and the treatment that's required. We also work through the state mental health facilities, and we also work through the jail system. For those individuals who do end up in the county jail or in the city jails where there is a persistent mental health issue, however, it's a grave misdemeanor or a felony, something that requires is going to require incarceration. We have linkages within the jail systems that allow us to get information onto the caregiver into the jail, and then when that individual is ready for release, that information is then passed back to the follow-up teams, where they can then ensure that the linkage from the jail to the community provider is completed. Outcome measures. Linkage is a very generic word. We look at that as one of our biggest goals. We are not a care provider. When I say that, the team and the unit, our goal is to link them to care providers. We certainly have relationships and understandings and agreements with different care providers. Our goal is to be that vehicle to facilitate that individual to that linkage. Sometimes we have those individuals who are non-compliant or resistant. Certainly we look through the courts and probate systems as far as conservatorships when an individual is unable to make their own decisions. Custody diversion, as I discussed earlier, is an option. We do have individuals who refuse services, and we do tally that because individuals, while they may fall off our screen or they may refuse services at this time, and we don't have what's called a hook where we can bring them in, we like to consider like waiting for a piece of fruit to ripen, because the opportunity will present itself, but at the time we don't force it if the individual is not wanting to be engaged by the team. We have those individuals who are transitory. It's very difficult sometimes to engage those individuals when they're out on the street. We do have street engagement teams, but it is something that we do tally as a measure. Arrest and custody, I talked about jail linkages. If they are arrested or they're placed in custody, we work through the courts and ensure that there's some sort of transition when the individual has completed their incarceration time. Numbers. Well, I went back and I looked at the numbers through 2000 first 6 months. Just to kind of perspective on calls for service, the camp teams receive an average of 30 to 40 new cases a month. Those are brand new. Those are not re-referrals. So the volume is astronomical sometimes. Of those cases, about 40% of them, we've had successful linkages. And it's just not a referral. That's where we ensure that the linkage is made and that the individual is embedded in that service provider's care. 7% we've gone to the public guardian's office and have successfully conserved the individual, where the individual is being either managed by the public guardian office, family member, or a responsible party. So 20% of the individuals refuse contact with us at the time. Again, we don't not re-engage them. We do attempt to re-engage them, but there are those times those individuals basically tell us to beat feet and they're not interested in talking to us. And 33% of the cases were managed via the criminal justice system, where you were able to receive some sort of mandated mental health services. And a lot of those are co-occurring in diagnosis individuals where there's drugs or alcohol on board, and get them into some sort of a sober living environment where we can then manage the mental health component is extremely important. The program's been operational for 7 years, and it's a proven success. We continue to assess the effectiveness. We're always looking for better ways to have a positive effect on the citizens we serve, resulting in measurable and better outcomes. It's a moving target, but we're always chasing it. So I'd like to thank you very much.
I appreciate both presentations, and we've had a number of questions that have come in, and I'll try to direct them, but some I'll let be a jump ball between Houston and Los Angeles representatives. The first question that came in was, what kind of support did you from your leadership on the development and implementation of your programs? And that would probably be answered by both of you.
I'll go first. This is Detective Dempsey from LAPD. The bottom line is without the support of the director of the Department of Mental Health and the chief of police and the community at large, the police commission, none of the programs from CIT to SMART and CAMP would not exist. You need that political will.
This is Odd, and here in Houston we have the support from the Chief Executive Operating Officer of our agency as well as the Chief of Police, but we also have the support of our City Council. We have support of our Sheriff's Department, and we had to, the way we initially got all of this community support was we had task force meetings for several years, understanding and realizing that this is a small percentage of the community who utilizes a large percentage of the resources. So that's how we decided to be proactive with this program.
This is Dempsey. I have to agree with Ann. Putting a dollar sign on it really brings, for the elected officials, a very important leverage to bring about their cooperation. You've got to be official on what you're reporting to them.
That bridges nicely into a question that was posed by someone on whether there are main talking points that you recommend when trying to get partners on board to be successful. And it sounds like you're suggesting that knowing your numbers and some of the cost avoidance issues are important. But what are the other talk points that you would use to bring this coalition together?
Very ill people. So as a society, have an ethical obligation to make sure that our societal members are safe as well as these clients. We have a responsibility to them and to ourselves to make sure that we take care of them. These are not people who have the capacity to pick up a phone and say, oh, I know that my symptoms are coming back, I'm about to decompensate, I need to check myself into the hospital.
Yeah, this is Detective Dempsey. I have to agree with Ann. Make personal, put a human cost along with the monetary cost is very important. You can't have one absent the other when you're doing a presentation to the decision makers. And having community support and then efficacy of other programs that exist somewhere else as learning sites. I'm sure Houston experiences the same thing, where these programs or these people looking to establish programs come from other entities now. While the laws, the structures of the different entities and their surrounding governmental systems might be different, there's a lot that can be said if you can show that it was a success somewhere else.
Sure. It was both a comment and a question that came from Tressa Johnson in Norfolk, in where they decided that their response to the population of high utilizers would include the purpose of, I believe it was as many as 65 permanent housing units that they now also provided support to. And the question was, is this a approach that other communities have used, and how do you sort of deal with the population of high utilizers that also are homeless?
This is I'll just speak for Houston. Surprisingly enough, this group that we're dealing with, the majority of them had benefits, them had a place to stay. They just were ill to stay in that home apartment. They would wander off.
District of Dempsey, I have to agree with Ann on that part, is the navigation sometimes becomes the obstacle, and the ability to assist them in that navigation and then set up supportive strategies so they don't fall out. But in LA County, they have a program that's called Project 50, and I invite the attendees to Google that. And basically what that is a supportive, they've identified the hardened, mentally ill street people, and they've engaged them, and they've put together a supportive housing strategy which basically has a wraparound type service model that is integrated into it. So, downtown LA with our homeless population, it's something that was necessary here in order to engage these homeless individuals and put them in a situation where we would be successful.
This is Fred Osher. That for those of you that are interested in our approach, while today's webinar has been focused on law enforcement approaches to the population, the Corporation for Supportive Housing has had a project for several years now looking at the frequent users of shelters and emergency services. That acronym is FUSE, in several cities, started in New York and now is in several cities around the country. And the corporation's sort of housing website has descriptions of the ways for the population that is out there, access to affordable housing with supports can make a big difference in their utilization of services. There's a question that is out there in terms of the capacity, the number of people that fit definition and criteria, and how you respond. We've heard that in Houston they have gotten a grant to expand capacity, but it still begs, I think, the question of, well, when do people leave your initiatives or graduate or transition back into less intensive services, and how do you expand or make the selection of the high utilizer population based on your own programmatic capacity? So capacity and then transition are the components of this question.
I thought that originally we would be able to pass them off to our clinic system within our agency. I did see that there was another question where the idea of ACT team, community teams was brought up. We thought that we would be able to pass them off to our community clinics, our ACT teams, but we weren't able to because the ACT teams have to operate under state mandates. They see them a certain number of times a month, and we see them as many times as we need to. We've talked to our ACT program within our agency, but these clients are chronic than those clients, and we've been able to pass them off. Some of the clients have been on the program since the very inception of the program.
This is Dr. Dempsey. That is a problem. When I say it's a problem, we came to the realization very, very early. One of the things we have that's an advantage here with our program and with the MU and the SMART is a dedicated database where all of that information is dumped into. So when we pull up a profile on a particular individual, we're able to see some historical perspective. Just to give you an idea, we had an alpha patient, the individual who inspired us to look at what we were doing and why we were doing it. And this individual has been with the program since 2004 when we looked at it. But what we look at is cycles, cycles of compensation and decompensation, and the ability for the individual to be managed. And there are times where 13 contacts in a year tells us there's a problem. We engage, we mitigate. The next year we may only have 2 contacts with that individual, and 15-month break, and then we re-engage them again. So it's cyclic. I don't know if there's a cure for chronic mental illness. If there was, perhaps we would be out of a job. But it is something that requires constant monitoring and constant engagement, and we measure by mitigating the contacts, but not by eliminating them. Unless individuals in a one-time crisis situation where the risky behavior was such that a singular intervention was successful, these individuals are with us all the time.
There was a question on ACT teams and how you might use an assertive community treatment team or not for this population. How would you choose one or another? I'd like to inform the audience that in our review of interventions for the group of individuals we will call utilizers, there seem to be 3 major types of responses, and they've got questions. The first of which is supportive housing responses, which we've addressed earlier. The second which are case management responses, which can be either in a assertive community treatment team with fidelity to that model or some other type of intensive case management program. And the third are the law enforcement-based responses, of which we focused on today. So I believe that in your communities you would want to think about what the opportunities are to use any of these to address the population that's being discussed at this point in time. I'd like to move on to another question about what are, and we have 2 large cities here, and I'll lump a couple questions together. And one is, what if you don't have a psychiatric emergency room or a place to drop folks off as an alternative to booking? How do you even identify the high utilizer population? And then secondarily, what ideas can this panel suggest to rural agencies that do not have the range of services available but still have those individuals within their communities that are regularly using a large amount of resources? So either of the groups for a response to those questions.
Well, it's a large state, so I know in Houston we are fortunate because we have a lot of services available, as I'm sure there's the same situation in Los Angeles. But for our mental health authorities in Texas, it's grouped with county areas. So there may be within that one area a facility. I recently at a conference at another area of Texas, and they were talking about the use of telemedicine and teleassessment through law enforcement having access to emergency rooms where they have psychiatrists and services staff on board. So that's a possibility, telemedicine.
Mm-hmm.
As Detective Dempsey, as a member of the MHSA, which is the Mental Health Services Act in California on the Innovations Committee, we looked at what counties with degraded or lesser mental health services programs could do with trying to provide supportive services. And one of the recommendations was some of the counties are actually starting to take advantage of a collaboration between the counties. So where one county, like the county of Los Angeles, is a behemoth, 2 or 3 smaller counties with lesser services could pool their resources and develop a response and intervention model that could be shared across county lines. And the ability to also establish community partners. I know some counties in the Midwest where they work with private providers of service who volunteer their time to work with the law enforcement agencies in managing these individuals who are experiencing health crises and or chronic caller service. And lastly, I'd just like to point out what Madison, Wisconsin did, one of the other learning sites, is, here's a department that, while they're, they have a fairly good-sized city, information sharing and technology is an issue. And the lieutenant there developed an Excel file of police contacts, took those contacts and was able to download them once a week to the laptop computers inside of the police cars, so the officers who are on patrol would have real-time information in dealing, when they're dealing with these individuals out in the street, as to number of contacts, type of contacts, and or contact information regarding family members. So I thought that was very resourceful on them.
And this is Officer Pate. I had one thing to add in reference to part of the question, and in regards to identifying high utilizers in the absence of a psychiatric receiving facility. Here with the Houston Police Department, we have an access database that we use. That each report that is generated by a patrol officer is printed within our mental health unit office. Each one of those, it's about 1,000 reports a month that are generated, and each one is individually read, screened for certain criteria, and each individual is put into our database, each interaction, and each month we run a report that basically pulls out how many contacts or how many police calls any individual has had, and how many emergency detention orders or any other number of criteria that we can find if it was a violent contact involving a CIT criteria. So that's the way we actually identify people for this program, is going through. We have to just literally do it the old way, just reading every single file or every single report and putting it into the database, and then that's how we find our list.
Sure. It raises then some of the issues around agency communications, and one of our listeners writes in, I'm curious how multidisciplinary teams have overcome the HIPAA hurdle, especially where law enforcement and mental health members of the team are housed in the same office or facility. I'm especially interested in this as it pertains to non-crisis outreach activities. So we've just been talking a little bit about some internal data collection that's done within the law enforcement agency, but this question is about that sharing issue. How do you share it, for what purposes? And we talked a little bit about it earlier, but I think a bit more discussion on this would be helpful at this point.
This is Dempsey. When I initially did my presentation, I talked about an MOA or an MOU, Memorandum of Understanding or Agreement, between agencies. And there's a strict understanding that the information that's contained within the mental evaluation unit is confidential and restricted information. It's the type of information that's not shared outside of the unit. So when a report is made or there's an intervention strategy that's going on within the unit, if it is a mental health fronted contact, a mental health driven contact, that information is confidential, and we don't even share it with our investigative partners or our partners within the command staff. It's extremely important to keep that relationship clean, so our mental health partners who are guided by HIPAA and subject to the regulations of HIPAA are not jeopardized. The other thing is we give a city attorney opinion based on the MOA and our relationship with our partners from the Department of Mental Health. When a mental health intervention occurs with our mental health partner and a community member, the officers, per interpretation of the law, are also guided by HIPAA, so they can't discuss and or share that information outside of that contact. Now, on the flip of that, if at any time that contact is converted to a law enforcement contact, evidence of a crime, something of that sort, then at that point the mental health intervention ceases, and it's made clear to all parties that this has now been converted to a law enforcement contact. So we have very defined policies on how we manage those situations.
Okay. encourage, again, the audience that would like more information on this information sharing to visit our Council of State Government Justice Center website, and you'll be getting information shortly. We have a document on information sharing that talks about the different entities, who's covered by which laws and what's allowed under what circumstances. So that's another resource that can be used to address this. There have been a number of questions about the case manager's role within your projects, and ranging from how many cases do they have, how often are they called, concerns about how intense and difficult the job might be, how they are paid for, can they bill. So I know some of that came out in the presentations, but there's a little discussion about the case manager and the specific role within your project.
This is Amy. I'll talk about how it's executed here in Houston. Someone asked if it's grant funded. No, it is not grant funded. We went before the City Council and asked for a certain amount of money. We were, of course, to provide justification for the amount of money, but we were provided that amount of money. It was initially a 1-year contract, and we had to produce the statistics, and they renewed it for another year and then another year, and then recently we asked for an expansion. So no, it's not a grant-funded position. The grant comes in from the psych tech, and that is just a specific amount of money for a certain amount of time. So this individual understands that when their time up, their job is up. So
the hours and intensity of the work, how is that managed and distributed across your staff?
Someone had a typical interaction with a client. The client may be picked up by law enforcement, taken to the emergency room, then they're in a psychiatric hospital. We hear that they're in the psychiatric hospital, so we go over, visit with them sometimes to establish a rapport. And yes, all of our clients are in our program voluntarily. So, of course, we wait until they're stabilized in the hospital to get them to sign consents to treatment, and then that consent is renewable every year. If they don't have a place to stay, we'll help them find a personal care home. If they have a psychiatrist, we have some psychiatrists who work with us. We will take them to the psychiatrist. If they need glasses, we'll take them to get glasses. If they need dental work, if they have elevated lipids because of some of these antipsychotics, we'll help them get in to see an endocrinologist. We are trying to provide services for the whole person. The case managers generally work 7 to 3:30 or 4, Monday through Friday, but there are extenuating circumstances where there will be a crisis at a personal care home or the client have a crisis after hours. So they do go meet them sometimes to do some problem resolution on site. Of course, then we're flexible with the modification of adjusting their hours for the next work week on that. You can't schedule a crisis with these clients.
No. This is Detective Dempsey from the LA County Department of Mental Health side. The vast majority of the individuals or the cases are paid for fee for service. They bill either the private insurance or Medi-Cal. The workload for the teams is dependent on the severity of the individual's illness and what their manifestation is. We try to balance that workload, although, as Ann was saying, you can't schedule crises and things of that sort. The teams are deployed 5 days a week, basically on a day watch type schedule. We cover from 6 in the morning till about 7 or 8 at night. And we have the advantage of having the smart teams, which are interconnected in this service model, where if a crisis does occur on the weekend, they're able to pull up and see that this is an active subject and what the clinician has been working with on the the care and treatment of the individual, the care plan, and then they can continue that model and then contact the clinician who had been working that case actively to let them know what the incident entailed occurred or off hours or on the weekend.
I'm going to lump a couple questions together here again. One asks, trying to track the call, interactions, and outcomes. Police calls come in many different ways. What's a good way to identify it as a mental health call? So there's this issue about 911 and dispatch, and I'd like the teams to talk to that. And I'm linking it with another question that asks, do you partner with the crisis telephone lines such as National Suicide Prevention Intake Lifeline or 2-1 if it's offered in your area to reroute people and try to de-escalate without in-person support? So it's about dispatch, and maybe the two groups can talk a little bit about how they identify and handle and respond to the calls that come in.
This is Lawrence Pay with the Houston Police Department. As far as the 911 side, one of those two incidents that I was talking about earlier from 2007 dealing with the gentleman called 911, and she stated in the aftermath that she told the police that her son had mental illness and that, she made them fully aware and they just came and killed her son. Well, looking at the dispatch, she actually did not mention it, and I'm sure in her mind, in all her frantic panic, that she thought she did mention this on the phone, but unfortunately she did not, and the officers weren't aware of the situation before they arrived. Well, that came a change in our dispatch system that now when our call takers answer any call, there are two questions that they ask in reference to if the call is in regards to someone's mental illness. And no matter what you call for, if you're calling for an auto theft, they'll ask you, is there someone there with a problem with a mental illness? And it sounds crazy when people call because they wonder, why are you asking me about this? But that's how we identify CIT calls. And so we can actually separate those calls and get them a CIT status and then attempt to get either CERT unit if one is available or get CIT certified officer. The dispatcher on their CAD system can see each officer's qualifications, and there's a little asterisk next to their name that says they're a CIT certified officer, and she attempts to dispatch a CIT officer if one is available. So that should be the first part of the question.
Mm-hmm.
For the city of Los Angeles, all of our 700 dispatchers have been trained in call triage involving persons suffering from mental illness. We have specific call typing, and the officers in the field and the dispatchers are given specific disposition codes when identifying a call for service involving somebody suffering from a mental illness. The other thing that we have for us that's unique, and of course, as Ann said earlier, we're resource rich. So, I understand when you're coming from a smaller agency or you're coming from a jurisdiction that doesn't quite have the resources we have, that some of this sounds very ominous, but we actually have a call center for the officers in the field, and they actually call into the call center, which is staffed by specially trained officers and a triage clinician, and they actually make physical real-time reports regarding that call for service, and the incident is documented, and that's how we memorialize outside of, let's say, the crime report or the other contact information the officer in the field might complete in regards to the circumstances which made or that officer to believe there was a mental illness involved.
Thanks. We have time for just a couple more questions. A couple of the listeners have asked if the program participants come in voluntarily or have been court-ordered, either via mental health court or some other diversion program. And so I wonder if you could address within your programs the voluntary nature of participation in your service models.
This is Ann in Houston, and the participants in our program are voluntary. We've had very chronic people that we would try to convince that they needed services, but they didn't. So we couldn't provide services to them, but our clients are voluntary.
The Detective Dempsey. The same thing, they actually, when the teams engage, if they do have the opportunity to engage, they do have consent forms. The individual can refuse services. I think in the page I gave on the statistical outcomes, we have those refusals, but the likelihood that the individual will become another source of call for service is high. So we just continually to try and engage on those individuals when we do get the refusal for service, and very rarely do we run into somebody who will not at least sit down and talk with us. But we do get those refusals, and it just requires us to be, how would you say, very diligent, and it can be frustrating at times.
One last question, and I think I may take a stab at answering it with our participants filling in the blanks, but it was about accountability mandated for nonprofit functions that receive federal and state funding, and how are these programs measured, and that I would suggest that it's variable across the granting and funding agencies. The Department of Justice, and in particular the Bureau of Justice Assistance, several grant programs that are relevant to this issue, one of which funded by the Mentally Ill Offender Treatment and Crime Reduction Act that sponsors the Justice and Mental Health Collaboration Program. And that I would encourage any of the listeners that are interested in thinking about starting up a program to go look at the BJA website where that program announcement is listed. It is a funding cycle that occurs every year as long as funding is appropriated, which still looks good for fiscal year 13, and that with that program announcement are some of the outcome measures that funder is particularly interested as it relates to law enforcement sponsored interventions. That program has funded over 400 grants in its lifetime, and many of which are law enforcement based, many of which have created some of the innovations that you're hearing here and discuss in this webinar. I think at this point I'd like to turn it back over to webinar administrators to tie up a few loose ends. I want to thank once more our participants for both the work that they do on a daily basis, the energy and creativity that they've brought to their programs, their willingness to share that with our audience today on this webinar.
Thank you, Rocher, and thank you to all of our participants and our presenters. I hope this information will begin to spark conversations in your departments and in your neighborhoods. Please feel free to get in touch with any of the presenters through this information and follow up with information provided on websites. So thank you all again, and I hope this information has been helpful. That concludes today's presentation.